Hello and welcome to QI Talk Time. It's Roisin here in Dr. Stevens, and today our QI Talk Time is from the National Ambulance Service. We are delighted to have Eamon Byrne with us today. He's going to talk about refusal to travel, elderly trauma and beyond. So Eamon has worked in the ambulance service for over 23 years. He's a master's degree in emergency medical science, a graduate diploma in healthcare risk management and quality, and has successfully completed the RCPI diploma in quality and leadership. And that's actually where I had the pleasure of meeting Eamon in the first instance. So he's completed projects on medication error reporting in the National Ambulance Service, refusals of care and transport to hospital, and the assessment of major trauma in the elderly, and has made award-winning presentations at international conferences at home and abroad. So he currently works as a frontline lead advanced paramedic in Carrow, County Galway. So thanks a million, Eamon, for joining us.
No bother, delighted.
And just a little bit of housekeeping for today. You can listen over the computer for sound, but sound is normally better if you phone in. So the phone number is there and the event number is there as well that you can punch in. And in the chat box, you'll see a little speech bubble on your panel on the screen, and you can just click on that. And if you have any questions or comments for Eamon, or you want to comment on anything or get a bit of chat going in the chat box, please do, and we'll address those throughout the presentation. Otherwise, we are active on Twitter at QI Talk Time. If there's a few of you in the room, take a photo, tweet it, let us know if many of you are watching it together. And without further ado, I'm going to hand over to Eamon, who's going to take you through his content. Thanks so much, Eamon.
Not at all, Roisin. I'm delighted to be here. I mean, the ambulance service is one thread that runs throughout the healthcare, acute healthcare. I mean, we've got 1,900 staff, we've got over 100 bases. You know, every year we do over 300,000 emergency and urgent calls, as well as our routine transfer in between hospitals and inter-facility transfers and, you know, discharges. So, I mean, quality improvement in the National Ambulance Service is something that's important to me, but I think it's important to the organisation itself. I see in the development plan, it's a stated aim now that we're going to try and develop our quality improver network and the facility of sharing ideas between our own staff. So the first part of the talk is when we were in the Royal College of Physicians, we took on a project on refusals to travel. Now, everybody in you know, any patient has the right to refuse treatment as part of their autonomy. But to make a decision, they need to be given information. That information was to be gathered by the paramedic and the advanced paramedic. Our medical director, Cathal O'Donnell, he put it into place as a guidance document for people who were refusing to travel to try and standardise the data that was being collected and the efforts that were being made to get people to hospital. In 2016, we noticed that the medical director, they noticed there was an issue. Our rates of refusal to travel, so people that were engaging with the ambulance service, but then subsequently refusing to travel or declining transport or declining treatment, was rising. It went up from under 8% up to over 11%. Now,
out of interest, you might know this off the top of your head, Eamon, but just interestingly, how many calls, like on average, would you get a year?
So the ambulance service is running at, as I said, the last figures I had were over 340,000 calls a year. Now that was emergency and urgent. My understanding is that about 200,000 of those would actually be designated as 999 or emergency calls. The rest of them could have been GP referrals and that type of thing.
Yeah.
So there's a sizable number of people. Yeah. Now these numbers in themselves are not too worrying. They're still below international levels. What was of concern was that we were also getting, at the same time, we were getting an increasing rate of serious incidents. When reviews were being done into these serious incidents, we found that although we had a policy, that our patient care documentation wasn't in some up to standard. So this was concerning to the leadership team, and between us, we tried to, it created a sort of a perfect storm. We were increasing rates, increasing incidents of harm, a policy that may or may not have been applied. So they wanted us to have a take a look at it. So this was the title of our project. It was Refusal to Travel, Patient Empowerment and Documentation Improvement. The patient empowerment part was really important to us because it's, as I said, everybody has the right to say no. Everybody has the right to decline transport. But in order to make that decision, they need to make an informed decision. So empowering a patient by giving them the adequate information was one of the key things that we wanted to try and get together. So on the team, it was led by Alan Watts, a consultant in emergency medicine down in Limerick. Paul Gallen was a chief ambulance officer down in the south. Sasha Selby was a graduate entry medical school in Limerick, and then I just came along just to make up the numbers. Like, we put out a driver diagram, so we wanted to improve the patient experience. And we thought by doing that, the primary things that we wanted to do were improve documentation quality. But again, as we were talking about, that assisted decision-making process. So we wanted to give the patient information on their vital signs, what was normal and what wasn't normal, our clinical impression, what did we think was wrong with the patient, the risks if they didn't go to hospital, and, you know, what were their alternative choices, what could they do other than maybe going to the ED. And we were going to achieve this by improved communication and documentation. Improving the documentation, we expected to deal with it by education. We found out that paramedics beyond a certain experience hadn't actually been shown how to, you know, what sort of information to include on a patient care form. This was kind of a concern to us, although we had the policy document. We wanted people to remember how to do it. We needed to audit it, and we needed to give our crews feedback on what they were doing. Improving the communication then between staff and patients, well, that was going to be a little bit more difficult to monitor. But again, the idea that we wanted to get across was that, you know, what was the patient condition? How were their vital signs? Were they normal? Were they not normal? And, you know, in any defence, we needed to be able to document these findings. We needed consistent risk information so that, you know, that we could make sure that everybody was getting similar sort of information. We also were looking at alternative pathways, trying to follow up with patients after they've declined our help. But again, we wanted to check out about the information received by the patient. The stakeholders diagram, obviously the first and foremost thing was the ambulance staff themselves. That was going to be key to getting them on board and getting anything. We focused this. I was based in Mallow at the time, and I have to say at the time we had an ambulance running day and night, and we had a response crew, a response vehicle. So we'd mixed clinical ability in the base, and actually our base was one of the first bases to change from a standardised paper-based patient care report to actually an electronic basis. That electronic patient care report is actually in the process now of being rolled out across the country. When we've got over 80 bases out of just 100 working away on this electronic platform. It's really fantastic, and we will talk about that later on. We needed the control, we needed information on the details from the calls. Our clinical information manager, Dave Willis, was a great help and great assistance. Our medical director, Cathal O'Donnell. And again, we wanted to try and engage with our patients and see what was important for them.
Maybe just to interject here at this point, Eamon, we do have a question from Roberta Gallahan. She's asking, do you have easy read information documents for people with special needs using pictures, etc.?
No, not at present. And one of the considerations that I had, there was a European health literacy conference that I presented this to, and they came up with some really good ideas. What I would like to see is our information being explained in easy to read, easy to understand way. Can a child understand it? That's kind of what I wanted. There's no point in keeping it technical that people are just looking at you blankly. So when we went into the staff engagement, if I could say anything, I would say never walk into an ambulance base with your hands hanging. Always bring cakes or always bring biscuits. It'll ease your passage. Fantastic. So what we did was focus group type interactions. I tried to aim these at the crossover shift. It maximized the number of people that were around, and it stimulated a degree of conversation. Some of these interactions then I followed up with semi-structured interviews, and then we also had an electronic survey that was passed out to one of our staff engagement forums in February of 18. So again, it was trying to get not just in Mallow, but trying to get a wider view of what the concerns of the staff in general were. So some of the comments that they came out, and anybody working in pre-hospital care can relate to this. So I can decide that a person is having a heart attack, and I can bring them to a cath lab in Cork University Hospital, bypassing the local emergency department. But I couldn't bring a cut finger to a local injury unit. People were concerned about drunks, people wishing well, calling an ambulance and then walking away, and an ambulance crew comes up and they're dealing with somebody that's intoxicated or maybe on drugs that didn't call an ambulance in the first place. So there were these real pressures on people. We asked people about what they thought about the policy. I'm long enough in the HSE. These were some of the comments. It was too long to read. It was overly wordy and complex, and that goes back into simplicity of language, and too long-winded. So we needed a way of getting our point across from what the organisation needed from its practitioners to something that the staff could use and in a practical way. We also, a comment that was made, sometimes, although we have these policies and procedures, sometimes it's easier to bend the rules. That's the reality of the situation that we deal with. Now, we did a process map of the thing, so we started off, but it was a very complex. It went over 3 or 4 foolscap pages. So I'm not going to put it up on the screen. But some of the things that came up was phrases, or people use their interpreting the information that they received from the control and forming a bias on what they thought was wrong. An example that a child that can't be woken up at 6:30 in the morning is in cardiac arrest regardless of what the screen tells you. It's just one of those things that you learn and you pick up on. So again, what we wanted to do, we needed to tap into what was actually the problem. So we did a randomized selection from the country. We did a patient care report, and we went back over them. We took about 75 records, and what we found was that the completion rate from Cahill's document left room for improvement. Now, interestingly, although we had the electronic PCR coming out, we found that there was higher completion rates with it. Now, this was part of, there are certain forcing functions that encourage you to make an entry. It encourages, it time stamps all your entries. So although the electronic patient care report was taking a little bit longer to a little bit longer on scene, the quality of information that was being gathered was far in excess of what was gathered by the paper records. From an audit point of view, it was so much easier dealing with the electronic PCRs than the old scannable paper versions. Again, just mentioning that about the electronic patient care report, 80 out of our 102 ambulance bases are now operational on it's absolutely fantastic. Dave Willis is running out that program at a rate of knots. It seems like only yesterday it started. Again, we'd heard people talking about the types of calls that they were being sent out to. So we did a retrospective examination of refusal to travel calls. We broke down, we got in with the ambulance control, National Emergency Operations Centre, and we started getting details on our refusal to travel calls. Found that the top three, the falls, the unconsciousness or near fainting, and just generally unwell patients. These were the top three categories of calls that were refusing to come with us. Now, I was at an Affinity Falls conference last week, and again, in the care of the elderly, we have concerns over people who fall and syncopate. You know, these are the people that seem to be slipping through our net. Going on information that was given to me at the lectures last week, these people may be inclined to have a reoccurrence over the next weeks, days or weeks. Now, that wasn't something that I was able to tap into on this project, because as it was only on the refusals to transport, but it would be an interesting measure to see how many people presented to either A&E or with the ambulance service. Interestingly enough, our call designations, a third of these refusals to travel had been designated as Delta. Now, Delta is the second highest acuity, just under a cardiac arrest, and you get an advanced life support response and a blue light response. So again, the ambulance service as an organisation has a risk-adverse policy to triage. It doesn't want people slipping through the net, and that's really reasonable. But again, to have a third of the calls that were refusing classified as Delta, you know, we felt that it could warrant an examination of the thing. That process of audit and re-examination, I think, is inherent in the ambulance control in NEOC, and it's a really fascinating place to get involved with or get talking to. When we looked at the times, we saw that they actually peaked between 8 and 9 o'clock in the evening. Now, that was nationally. In the southern area, then, we got that same peak between 8 and 9 o'clock, and also 12 to midnight to 1 o'clock in the morning. What I would have hoped, what I would have liked to have been able to do was express these numbers as a percentage of the calls that were outstanding, so that it was a busier time of the day, so that was why we had more refusals to travel. I wasn't able to get that information. It also coincided with a changeover in shift, a traditional 8 to 8 shift. So this was something that we were aware of, and we thought there might sort of need further investigation. So the last piece that we did was actually a risk assessment on, you know, spending time and money on people who didn't want our help. And so because historically the ambulance service, we tried to do a sort of risk analysis of the refusals of treatment and transport. So we found out that according to Slattery, the ambulance service was rarely the subject of litigation. People still like us. We had 24,000 refusals to travel in the year. A different paper then said that the mortality rate of non-conveyed patients compared to discharges from emergency department was or the mortality rate of non-conveyed patients went between 0.2% and 6%. And that patients not transferred to hospital had twice the death rate of patients who were discharged from hospital. We combined that with a paper that said that 10% of our patients or our families that we had dealt with wouldn't be happy with the non-conveyance decision. And then we made out the average cost of the claim. We reckon that there could be, if they took a mind to it, between 2 and 75 litigants, and our projected annual risk was between 280,000 and 10 million a year. And we're nowhere near that, but it puts it into context, you know, to be defensible in an action, you know, we need solid and robust measures and documentation for the State Claims Agency to defend us. Again, with that, we had this anecdotally staff stepping outside the protocols to make alternative arrangements for patients. This might have been ringing a GP or trying to arrange an alternative appointment for other than ED. But again, it was there and it was stepping outside the protocols. And organisationally, none of our personnel, with the exception of 4 community paramedics, the majority of our didn't have permission to do this. So again, it was coming back to that, sometimes it was easier to bend the rules. So we put into place 3 Plan, Do, Study, Act cycles. The first one was an education piece, much like what we've just been discussing. It was highlighting the times the calls came in, people, you know, the dangers and the risks associated with leaving somebody behind, and then, you know, encouraging people to interact with us. We had the policy document, but we needed it in a transportable fashion. We needed it in something that could be carried around and accessible with all the paramedics. So what we did was we printed all our paramedics, all our pre-hospital staff carry what we called a field guide, and it's a kind of reference, small little reference book, it's notebook sized. But we made up a sticker that we could just stick in the back that summarised all of the information set out on COHL's policy document. Right. Again, that was, and what it did was it expanded on some of the points, and it, you know, highlighted that if you were going to rely on information later on, that it was a good idea to have it written down on the patient care report. And again, we tried a trial refusal to travel form. We had mixed success for that. So how did things go? Well, overall, we had improvements across the board. Our average completion rate jumped from 63 to 83%. Our median completion rate from 73 to 96%. And you know, it was quite successful. Interestingly enough, when we measured the breakdown of the call times, we found that the calls actually leveled out in we didn't have those same peaks that we had nationally and in the southern area. So this was the time of calls for the ambulance service in Mallow. Again, we can see at that 8 o'clock, there's no peak there. Again, these were the comparative documentation rates. Again, the bottom line is the before intervention, and the second line is the top. And again, you can see there that it was the idea with COHL's documentation was that one, that we wouldn't have that we'd have 2 sets of vital signs, that it wasn't just a snapshot, it was a progression, that we could see if a person was getting better or worse or staying the same. So everything was doubled up. We also felt that it was good to have you know, that non-required free text for the practitioner to paint a picture of what was happening at the scene. So overall, with the documentation, we felt that it was a success. Again, one of the problems that we had the information recorded, but it was difficult to determine how much information had been passed over to the patient to facilitate that shared decision-making model. one of the things that we felt that did come out of it was the development of alternative treatment pathways. Now, there's been a community paramedic has set up. 4 of our advanced paramedics went on and have expanded scope of practice. We have, I could be corrected, but I think there's a couple of schemes going on around the country where injuries to local injury units are being investigated. Again, it's not on a general rollout, but it's just, these are things that are being looked at the moment. Sorry.
And Eamon, sorry to interrupt, but I'm just wondering, you had 3 different interventions there, and that you talked about, the education and the sticker. And do you have an inkling as to, do you think it was a combination of the 3 that seemed to lead to the improvement, or do you think it was more so one than the other? My feeling is that it was a combination. It was a combination of factors. The education, when it was explained to people what was expected, and why it should be done, as opposed to just, this is what is done. It improved that participation. It gave them a reason to do it. The aid memoir, in some ways, once we moved over onto the electronic PCR, was a little bit redundant insofar as that the electronic platform had its own built-in sort of forcing functions. So, for example, any free or any text that was required was built into the system. Vital signs were time stamped. You wouldn't be able to close down the system without taking a number of set of vitals. So it was a combination of our efforts, but also the confounding factors of the rollout, that national rollout of the electronic platform. Yeah.
So one of the key points on any quality improvement, we have to talk to the patients. And one of our problems with our patient was that our initial rollout was that we had gotten verbal permission to contact them afterwards, patients afterwards. Well, sort of with the advent of GDPR, we kind of ran into a problem. We felt that we had to get written permission. So again, our interaction with patients was a little bit more limited than I would have preferred. But we did get a 92-year-old lady who, and her daughter, they gave us permission, they gave us consent, and they were contacted then afterwards to talk about their experience of the ambulance service. Both of them felt that they'd been given enough information to make an informed decision. They both felt part of the decision-making process, and they were 100% confident that it was the correct decision not to go to hospital that night. On a plus side, the paramedics were extremely professional and caring, and they didn't feel that they were just doing a job. What's really nice is that the patient felt that our staff wanted to do the best for the patient, and that's what it all comes down to. That's why all of us are out there. Take a breath.
Yeah, great. Thanks a million. And there's plenty of people online, actually, and we've 47 people online. So Eamon is happy to take any comments or questions or queries from anyone online. Someone did mention that the sound was acting up, so the dial-in details are there for you, so please do that. And I think that's something, that last point that you've just brought up there, Eamon, about including our patients, that is a challenge in terms of, getting access to patients, getting forums through which we can discuss. And there are different accessibility platforms through the HSC that we can use in terms of getting patients for committees and getting patients. So it is getting a lot better and a lot more easily accessible. So, sorry, Eamon.
One actually, as part of the project, I tapped into the HSC Patient Voices program. And one of the resounding consistencies in the stories that they told was about how our staff made the patient feel. It wasn't about the clinical decisions we made. It was about the small touches, the pieces of comfort. You took my mother's pain away. You stopped her vomiting. You gave her a blanket. You made sure she was warm. You made sure she had a pillow. And in this day and age of key performance indicators, sometimes we forget actually the important things to our patients are actually the self.
Yeah. Shane Devlin has a comment here. Are aid memoirs going to be made available to frontline staff for patients who refuse to travel?
So with that procedure, I got a number of them printed up. If anybody wants to contact me, again, what I was hoping to do was get them incorporated into something like the field guide. But I still have a number of them. If anybody wants to contact me, if they think that it would be of help, I'd be delighted to share them. And organisationally, I'm available. I'm around.
And the slide set for this will be up online on the QI Talk Time webpage, and we will put in Eamon's email address into the back of the slide, so you'll have access to that after the talk time.
So I suppose we can. Yeah, sorry. So one of the pieces that I'm currently involved in is assessment of major trauma in the elderly. This was a piece that we started with UCD last year on the graduate diploma in healthcare risk management and quality. But one of the things that came out of it was when we used the information that was available on the major trauma audit from the National Office of Clinical Audit. So when we were talking about major trauma, it was serious, it was life-threatening, and often multi-system traumatic injuries. Now, where does this happen? Well, it happens at home with falls of less than 2 meters. Now, that's not very dramatic. And when I came into the job, first of all, it was the high-speed impacts, the car crashes, the falling off ladders. It wasn't little Mary falling in her sitting room. So our energy mechanisms have changed from those high energy impacts to almost, I heard somebody using the word stealth trauma, these low energy mechanisms, and they may not trigger our existing major trauma protocols. Any of us know that major trauma it needs to be recognized. If it's not recognized, it can delay our definitive treatment, whether that's a local bypass protocol or whether it's moving on to just even interventions that can be done in pre-hospital. We saw that from this major trauma audit, we saw that 44% of our patients are actually older than 65 years. That's a high percentage. And why is that important? Well, our pre-hospital triage systems, it may not account for the older patient. It may not account for the older patient, the one with the on medications, the one with the comorbidities. So, and as a result, our patient's condition, they could be wrongly classed as stable when they're actually quite seriously ill. Now, FEC is the Pre-Hospital Emergency Care Council, and all pre-hospital staff in the country are required to be FEC registered. And they set the clinical standards for all pre-hospital care. As I said, when we look at the major trauma audit, we notice that the older you get, the less likely you are to be subject to a hospital pre-alert. So a pre-alert for anybody is where an ambulance crew recognizes that a patient is sick and can ring ahead in maybe 10 minutes, it may be a half an hour, it could be an hour, but it gives the emergency department a chance to gather its staff, gather their resources, and in this day and age, clear a space. But the older we get, the less likely we are to be recognized as a major trauma. So this is an issue that we're hopefully going to try and deal with. At the moment, we've made submissions to the Pre-Hospital Emergency Care Council highlighting this, and we have been asked to present at the Association of Emergency Medicine up in Sligo next month. So it's kind of a really interesting time to get involved. I just say, well, like one of a really nice thing happened yesterday was that it was one of our newly trained paramedics contacted me, said it the advertisement for the QI talk time, but he said, Eamon, he said, I have an idea for a quality improvement project. I said, brilliant. You know, you've got new faces, new ideas. You know, I can't wait to get these people together in the same room and start making the most of it. The ambulance service has started, and it's onwards and upwards.
Great. Thanks so much, Eamon. Lots of lovely thoughts there and information for us. And I suppose for people online, what's really important as Eamon talked through his project was the fact that, you know, he touched on a lot of the quality improvement tools that we would use in terms of QI methods. So the PDSA cycle, the stakeholder mapping, the driver diagram, the measurement plan. So all of those things are really, really important when you are working through your QI project. And I suppose as well that measurement plan leading to then display of measurement and how you display your measures. And I think Eamon showed nicely there with his run charts, the pre and post, and the difference between after he'd implemented his changes. Here in the National Quality Improvement Team, we are delighted to say that we have developed a quality improvement methods toolkit, which will be going up live very soon online, and we're going to do a QI talk time on that. So I think a lot of our listeners and followers will be really interested in that. It's a one-pager toolkit with, I think it's 16 tools in total, and an introductory booklet which tells people a little bit about what quality improvement is and the model for improvement and a little bit of theory behind it. So I think for staff on the ground, I think that will really help anyone who's thinking about doing a quality improvement project and using the tools to support them in that. You're very quiet on the chat box. There's not too much questions coming in there. So without further ado, I think I just really want to thank Eamon for coming and sharing some of the improvement work that's happening in the National Ambulance Service, and we hope to have other people join us over the course of the QI Talk time over the coming weeks and months. So anyone from the Ambulance Service who's interested in joining up for QI Talk time, please let us know. You can join by emailing roisin.breen@hsc.a or Naomi Palacios, which I hope I pronounced right. Naomi's here. She helps me deliver the QI Talk time. So please email us and join the mail list. Our next QI Talk time, over the coming weeks, we have some pop-up QI Talk times which don't fit with the normal Tuesday schedule, because we have some experts coming over to speak at other conferences, and we're tapping into that and availing of their time in Ireland. So on Friday, we have Heather Shearer, who's going to speak to us. Heather is a quality improvement coach from Scotland and a member of the Sláinte Care Advisory Council. She's going to be speaking about thinking up. Really, it's about cognitive biases and considering how they interact with decision making. And the mail list, it's up on the website, but the mail list would have received a flyer on that, and it will be advertised on Twitter. So without further ado, we'll hopefully see some of you on Friday. And thank you again, Eamon, for coming and joining us today. Thanks very much.